Thanks very much, Sophie. Can you hear me all right? I can hear myself, so that's good. All right. Here we go. So to start with, I'd like to acknowledge that we're on the lands of the Ngunnawal and Ngambri people. I pay my deep respect to their elders past, present and those emerging. I'd also like to acknowledge any Aboriginal and Torres Strait Islander people here or dialing in. And I want to acknowledge Louise Lyons, who unfortunately couldn't be with us here today. She's unwell, but a lot of what I'm presenting really is her work. And it's humbling to be able to present work done on the shoulders of people like Louise. So thanks for having me. All right, so as you heard, I have practiced in Aboriginal health service in the past as a clinical pharmacist, and so I guess my perspective today really comes from a practitioner perspective and trying to think about translating that environment into a policy environment and working with policymakers and decision makers to ensure that outcomes and policy is really appropriate and fit for purpose. I had the pleasure of working in Danila Dilba Health Service in Darwin as an integrated pharmacist into a multidisciplinary team there. And then I've done a bit of training around public health and some other things as well. So I work for NACCHO, which is the National Aboriginal Community Controlled Health Organisation. We represent around 145 Aboriginal community controlled organisations around Australia. Our organisations are health organisations mostly, but they have a remit which is very broad. It's often related to health justice partnerships, education, housing, and I think that's really a lens that we try to take into all the work we do at NACCHO, that health really is beyond just a biomedical lens, and our members and the community-controlled sector that we deal with are about solving problems, health problems in the communities in which they operate. They're local Aboriginal and Torres Strait Islander boards who are accountable to the communities in which they work. And I think in a lot of ways that the model's over 50 years old now is somewhat an exemplar, I suppose, of multidisciplinary care. I've just tried to include here a bit of a description about how ARCHOs are a key implementation arm of our national health infrastructure, but also a key stakeholder in terms of actually driving policy to then be implemented. So I think there's probably some circular concepts that might come in through this presentation. So as I said, unfortunately Louise is not able to join us here today. I hope you're dialing in, Louise, and hello if you are. Louise is a proud Jadwa woman from Western Victoria, and she works for the Telethon Kids Institute, TKI, as a Senior Manager of Strategy and Policy, and is also involved in the ALIGN group, which is the Australian Alliance for Indigenous Genomics. I guess I just want to reflect on their principles just down below there of sovereignty, equity and benefit, and I think it'll be good for us to kind of think about that, I suppose, in the coming few minutes during this presentation. So ALIGN is a national group, I suppose, but it consists of a lot of different players. It really, ultimately, my understanding is that they're trying to privilege the voices of Aboriginal and Torres Strait Islander people within the Indigenous genomic space and make sure that there's that voice there and that equity. Just an illustration of some of the organisations involved in ALIGN. There's a big depth of players, I suppose, all across the country. So I want to talk about governance today because I think it's really central to the idea of equity, and especially for Aboriginal and Torres Strait Islander people to have a voice in the cancer space generally and rare cancers. So this is a model of governance for the ALIGN group, and I just want to highlight a couple of things. To start with, you can see the jurisdictional nodes there in orange, and so there's almost a federated system of different nodes that have specific programs which they manage, but then each of those nodes contributes to the overall governance structure of the ALIGN group. And as I said, there's a cyclic approach to governance here. So governance groups can form a policy which can then dictate what data and information is collected and the lens in which those data are actually understood. And that knowledge is then builds the actual capability of the network themselves to build the strength of that governance and the intelligence that comes from that data. So I think that's a really important concept to understand. And I've just highlighted a few broader principles around Aboriginal and Torres Strait Islander governance, which Louise put together. So one concept that some of you may have heard of is around Aboriginal and Torres Strait Islander ways of knowing, being and doing, which in some ways is almost a reflection of sometimes a completely different worldview to the biomedical world which we all operate in. And I think governance, Aboriginal and Torres Strait Islander governance job in some ways is to really help translate and work between those two worlds to bring the lens of elders, knowledge holders into the lens of the mainstream health world that we operate within. On a more practical note, governance groups can really help any organisation or consortium build their cultural competency so that that interaction between Aboriginal and Torres Strait Islander participants, organisations is really effective and appropriate, and the communication works really well. Specifically for Align, as I said, there's state and territory committees as well as a National Indigenous Governance Council who are really important in terms of buy-in and understanding some of these big systems. So on that council are some relatively well-known Aboriginal and Torres Strait Islander people, including, for example, Lorraine Anderson, who's also on the Medical Services Advisory Committee. So I think having the broad perspective within governance, I think, is really important given all the different elements that are within these within genomic therapy. So I just want to change direction a little bit and just talk a bit about clinical trials. And Louise had highlighted this article. I suppose the general inference from this slide is that within the Prospero umbrella review, the benefit of participating in clinical trials is pretty well established. Within the cancer sub-review, over half reported statistically better outcomes. So I guess in some ways this presentation is predicated on the idea that participation in clinical trials is a positive thing. However, looking at the Australian and New Zealand clinical trials registry data, not that you probably can see all of the detail here, but in summary, of the over 18,000 clinical trials, only 0.8% of those focused on Aboriginal and Torres Strait Islander people. And perhaps even more importantly, at the moment we don't really have a sense about who are the Aboriginal and Torres Strait Islander people actually participating in any clinical trial. We don't know those data at the moment, and I think that in some ways that's really central, thinking back to that theme of the cycle of governance. If we don't have that information, it's hard to lead and know what really are the priorities within this environment. And then looking at those clinical trials that do focus on Aboriginal and Torres Strait Islander health, at the moment there's a relatively specific focus, and it's not necessarily on cardiovascular disease or cancer, for example. So we do know within the cancer trials within this registry, 18 specifically have Aboriginal or Indigenous included within the description, which is less than 1%. And of those, there's only 8 of those which actually we're talking about the most prevalent types of cancer. So I think there's somewhat of an incoherence between strategically what cancers should be targeted within clinical trials for Aboriginal and Torres Strait Islander people and what actually are. So I'm not saying I necessarily have the answer to that, but just highlighting that there's not necessarily a clear leadership within that process. So Louise has referenced a few things here in relation to barriers to access. So while we don't know how many Aboriginal and Torres Strait Islander people are actually accessing clinical trials, we do have a very good understanding of why Aboriginal and Torres Strait Islander people don't actually engage with health service providers more generally. Many of these are quite well documented in the literature, but some of these are specific to clinical trials as well. And cultural safety, for example, as well as probably one of the more common ones that's referenced to me is the idea of Aboriginal and Torres Strait Islander people who may have a higher burden of chronic disease being excluded from clinical trials for that reason. All right, so specifically, Louise has also referenced a few very real things for Aboriginal and Torres Strait Islander communities in relation to genomics, whether that's around misuse of biosamples for justice, police kind of purposes, or even some association between the eugenics movement and genomics. So these are real barriers that are being fed back to Louise within her work she's doing, and something that we need to acknowledge. As I think has already been referenced, maybe by the Minister, is around the actual disparity in cancer outcomes. Cancer is now the leading cause of death for Aboriginal and Torres Strait Islander people, and you can see the graph here, unfortunately, the way that trajectory is going. It is really positive to see a recent investment of, I think, over $300 million from the government, but it's still, I think, thinking about the horizon, we've got a long way to go to change that curve. Louise also wanted to highlight on that last point, while we kind of know that the screening rates, and I suppose this relates in some ways to the moonshot document, the screening rates are lower for First Nations people, and diagnosis often occurs at a later stage. Understanding why that is potentially quite complicated, and Louise is interested in unpacking that from a genetic perspective to see what are the genetic components of that. We've just got a bit of a slide here on cancer of unknown primary. I suppose reflecting on the paucity of data for Aboriginal and Torres Strait Islander people, we don't necessarily have a lot of data around rare cancer at all. But looking at the cancer of unknown primary, Louise has highlighted here that it's about double the rate for Aboriginal and Torres Strait Islander people compared with other Australians. Some work that's been done there on that. Just, I suppose, changing a little bit and highlighting potential success stories or ways that things can work. The first example is HEPATA, which is a project really looking at hereditary pancreatitis, which is a very specific condition that Aboriginal and Torres Strait Islander people unfortunately suffer at a much higher rate than you can see than other people within Australia. And so this project is really trying to build some of these concepts we've talked about in terms of Aboriginal governance, and also around data as well, to actually build a purpose-built registry, I suppose, for people with this condition. Okay, the other one, which is not quite related to cancer, but I just wanted to highlight it, is around a randomised controlled trial. So I guess in my own personal experience dealing with some industry from time to time, we don't necessarily see a lot of direct engagement with our member services, the ARCHOs. And when it can happen, I think we can have true structural kind of reform which can improve outcomes. So this is an example in the Kimberley where a pharmaceutical company worked with a community-controlled organisation to develop an RCT which was shown to be superior to that previous antibiotic that was used, and it actually led to a successful PBS listing. So the community had defined the need, from a governance perspective, and then they collected those data, which were then used to inform a policy to change the PBS. So I guess just reflecting on all of this and thinking about what are the outcomes that we're really looking for. Ultimately, and I hope I'm not over-inferring my conversations with Louise, but having a culturally safe environment where clinical trials are accessible and treatment is accessible is in some ways a vision that we have within our sector for Aboriginal and Torres Strait Islander people. And then the sequelae of that, I suppose, is that the outcomes for Aboriginal and Torres Strait Islander people, or specifically survival rates, for example, are improved. Speculating on how that might occur, we both thought that a national system that's targeted at collecting, collating and publishing Aboriginal and Torres Strait Islander people screened and enrolled is really important and central to that cycle of governance that we were talking about earlier. So what that system looks like, I suppose we don't necessarily have a lot of detail, but there's certainly some other factors that might inform that system. We've highlighted a few things, for example, like improving ethics committees' capacity to be able to understand clinical trials and provide helpful advice to people conducting clinical trials to make them as culturally safe and as appropriate as possible. So this is not my teenage daughter's room, but I thought I'd put it in there as a bit of an illustration of what the policy environment can look like. So while success can have many fathers or parents, and failure is an orphan. Sometimes it's hard to know, as a parent, I suppose, where to start in terms of organising and herding the cats, so to speak, to actually find some of this change that we talked about in the last slide. So I've just listed a few stakeholders that I deal with, I suppose, professionally in my role at NACCHO, and I really just want to highlight, I suppose, the importance that we stay grounded in the communities that we represent, and that they're really our North Star, I suppose, for what those outcomes should be. But I think all of those groups that I've referenced there have a really important role to play, and we as a sector need to engage with all sorts of providers to actually achieve these outcomes that we're hoping to achieve. I wanted to highlight, some of you may be familiar with a framework that we have for working with government, which I think really can be applied across a lot of different sectors for working with Aboriginal and Torres Strait Islander people. Many of you may have heard of the National Agreement on Closing the Gap. And within that, we have some priority reforms, which are around making mainstream care more appropriate and mainstream organisations more appropriate for Aboriginal and Torres Strait Islander people. Data is in there again. It's very important that data is managed well, that the right data are getting to the right people. Local data is a really important thing, whereas for Aboriginal and Torres Strait Islander communities, there's a strength in diversity, but also that diversity needs to be understood at a local level. So the prevalence of a cancer may be very specific to a community, so national data may not be particularly relevant, for example, in that environment. The Commission, I'll talk a little bit about. I think they've got a really important role in terms of setting standards for healthcare providers. And also, I think within the Moonshot document, there's discussion around specialist access and looking at cancer treatments coming through at the moment. Accessing specialists is something we know that Aboriginal and Torres Strait Islander people, there are barriers to those pathways to access specialist care, and probably more than I can go into now, but I think it's worth acknowledging that we need to work with professional bodies like RACP to try to support that. So we have been involved in some policy recommendations congruent with some of the things I've discussed today. We're involved in the Senate inquiry and had recommendations which are consistent with what we've been discussing in terms of those priority reforms I've just referenced. And the other thing, just to re-highlight, is the importance of health in all policies, or considering cancer from a very broad perspective. A lot of our members work in environmental health or education, so we're very keen. I acknowledge that, you know, as a pharmacist, I suppose I often think about medication, but within this policy, it's very important, or within our response to the inquiry, the importance of really thinking about cancer very holistically is really highlighted by our member services. So regarding the Commission, I'm not even going to try to pronounce that acronym. We have now, NACCHO has an MOU with the Commission, and we're hoping to really build the impact, I guess the mutual impact in some ways that we can have between our organisations to improve the standards and the capability of healthcare service providers around Australia. We want to make sure that clinical support for cultural safety is really improved. One idea that's been proposed is a framework when organisations are commissioning cultural safety, that there's a framework to appraise the validity of that cultural safety training. At the moment, there's not really a national framework that any organisation can go to and say our cultural safety is accredited, so we know that the people who are being trained are really proficient, I suppose. Louise is reporting back that the clinical trials registry are in favour of specifically collecting Aboriginal and Torres Strait Islander identity. We have a farmer group that NACCHO manages, and we've had a commitment from that group to try to build Aboriginal and Torres Strait Islander status within the actual clinical trials forms that are used, which actually we've needed to go to a global level, I suppose, to have that field actually included within clinical trials infrastructure, apparently. So that's in progress, which is positive, though I've been told it's maybe 1 or 2 year horizon to change that field. So it will take a while, I think, to get things done. And then this is Louise's final comment, and really just highlighting the importance of genomics and the importance that Aboriginal and Torres Strait Islander people aren't left behind, and that there's that governance and data that is imbued throughout the entire ecosystem, I suppose, that we're within. And this is some acknowledgement of the financial contributions that Louise has received as well. Thanks very much.